Hello, my name is Dr. Adam O'Brien, and I am going to lead you through a little bit of a concern I have. Judging by the title of this, um, you may be confused by it if you are tapped into the work of Bessel van der Kolk. I am tapped into the work of Bessel van der Kolk and have been, and basically have built my dissertation on one of his observations around, and team, I'm sure, that there's an addictive quality to people being addicted to the trauma. He wrote a paper with a similar type of title, and kind of highlight some key things for me as to really try to understand how addiction really does fall into the traumatized pathology, and what does that mean and how does that work. That's the mainstay of my work. However, so I recently saw, and this is January 25th, 2024. He mentioned that psychedelics, particularly MDMA, where it was really helpful for developmental trauma. And if you read his book, The Body Keeps the Score, he has a specific portion in there that he talks about, like, developmental trauma disorder and how it should be a disorder. And so my take on it is that no, it should not be a disorder. And here's my case. And to kind of surprisingly, as you get to know me, you would be somewhat surprised that that I would support the APA in such a thing as to, like, not making this a diagnosable disorder, namely because the ACE study in 1994, 96, they discovered, in a traditional kind of like question and answer type of thing, that trauma is normal, that over 90% of people have some trauma from childhood. And this was from an obesity study of trying to, learn as to how obesity and emotional experiences may have been shaping people's um, uh, metabolism, in a sense, or like their lifestyle, and however that kind of pans out in the sense of, like, what their findings were. But basically, a lot of people have trauma, if not everybody, so that makes it the norm. You can't diagnose something that is normal or is the norm. So that is one aspect of it. The other aspect of it, it doesn't mean that it's not a disorder in the sense that it creates disorder. That is, for sure, but it's relationally based and it's attachment based, of which attachment disorders is another, way of saying developmental trauma, and that is also not a diagnosis, because that is normal. And he cited, I believe it was in the book, Body Keeps the Score, that, like, we already have the research, and it sounds like I'm remembering it being more of a speech, that they have the research, particularly on, like, adopted populations and or residential type of treatments, and that, like, there is something significant to developmental trauma that is something that does impact people's ability to grow and develop, and as we can call normal. But again, the norm is to have been traumatized at some point in our lives. Whether or not it's still unresolved is the question as well. And unresolved trauma is going to produce symptoms that are often going to be related to ups and downs and depressions and anxieties and bipolar in a general sense, but also, dissociative underpinnings around ADD, OCD, and these types of things. So part of what my work, addiction as dissociation model, highlights, is that addiction is also transdiagnostic. Dissociative disorder and disorders and trauma are seen as transdiagnostic, and my work is to really show how addiction is that as well. What I would implore, I guess, the people who are thinking that we need to have, this as a diagnosis, you know, and or that, everybody, somebody fits something in that book. In the DSM, the Diagnostic Statistic Manual of Mental Health Disorders, put out by the APA, the American Psychiatric Association. So one of the things that I would have people think about, particularly clinicians, but also clients who are trying to be informed as to what is this thing that we are doing what we call therapy. So I have been polling therapists for some years now, related to how much time they are spending on developmental trauma. And in session, how much people's time is used for really treating and addressing, talking about developmental trauma. Now, these are mostly therapists that are trauma trained, of which, being a transdiagnostic, I do think everybody should have some training in it and some understanding of it, which on the whole, there is that people do have some training, but there's definitely more that we could be doing, and definitely in the area of, I would say, trauma, particularly dissociation and addiction, of which is, the mainstay of what I do. So people who have the experience of developmental trauma are going to have symptoms of distress, right? And if that is the mainstay of what people are talking about in their therapy, of which people that I have polled, most were 75 to 90%. Others were 50 to 75%. So definitely over half of people said that their time, everybody said everything above 50, so that's like 100%. But people kind of captured that, reasons why, it was lower for them or whatever, but just a straight up question as to what is the amount of time that you spend, developmental trauma disorders or attachment disorders. So we'll say 75% is kind of the median there. Technically, it's not a diagnosis at this time. So should it be is another question. If it's the norm, then no, it shouldn't, because then everybody would have that diagnosis. Now, we also have adjustment disorder, which does fit into that. But that should be about 3 months. Now, here we start talking about what is called medical necessity. Medical necessity is a standard in which insurance companies, and I'm sure governmental regulations and or expectations, but basically the system's version of is it bad enough? And for us as clinicians, it's bad enough if you're reaching out and asking to come talk with somebody. Either you are emotionally able to know where to get your needs met, and that's hopeful that the person that you meet can do that and meet you where you're at. And typically we have a diagnosis that could meet whatever it is that you are coming to us for. And they also have lower levels of diagnoses or situations, I guess, that fit into something, but they're not diagnosable in the sense of billable. Now, those are called V codes within the DSM. So V codes fit more of these types of situations. And trauma processing can involve, and usually has to involve, some level of connection to the developmental trauma disorders and attachment disorders, because the reality is that's usually what people are coming from, and that is usually where the most of their hurt happens. Now, I do make a general statement that is attachment disorders and developmental disorders, traumas, I guess, are what make complex PTSD complex, because there are many, many layers to it, and it's usually involving parts and or inner children and these types of things. Now, that's a whole nother thing that I'm not going to necessarily go down, not too far, I guess. I mean, what I would want to capture in a very short period of time is that, in 1980 was an abnormal response to an abnormal event is what trauma was. Now, an abnormal response is not what we found in the early 90s of when the ACE study came out telling about how trauma was the norm. And then we found out that dissociation was the norm. And my work in 2023 is about how addiction is normed and universal, and it is related to people having, depending on their addiction. This goes back to Kolk and him pointing out that you can become addicted to your trauma, and that what that process looks like. Now, built upon that, I would advocate for not having a developmental trauma disorder, because when you start diagnosing normal, when you start giving more power to the powers that be to imply that somebody has something that they need fixed, we start to go down the rabbit hole of what is mental health, what is, who is labeling what, and what is it really? Well, it can be trauma, but not diagnosable. It may not meet the medical necessity, and which is, I think, the argument of the APA, is that this does not meet the criteria for a medical necessity. Now, it doesn't mean that it can't or doesn't, or if there isn't another diagnosis that fits into it, sure, have fun at that. I am looking at this more as a seat of advocacy, because the people who say, like, everybody should have a therapist, everybody should have somebody in their life. If a therapist, a licensed therapist, is somebody who is trained to help somebody with a clinical diagnosis, then they should meet the criteria for a clinical diagnosis. And should licensed professionals be able to treat below their grade, we'll say. They have the same skills, they have the same knowledge in general, maybe over. Is there a middle ground for another profession to come in? I would say on two ends. One is that there is a need for, I would say, more of a coaching model for people for developmental trauma disorders. Now, that may be a concern to people in the field that say that, like, well, they don't have enough training. Well, this is why I suggest a higher profession than psychology, and I would argue the medical model, and I have several papers that I and finalizing in the near future that will kind of highlight the exact kind of line of thinking that I have. But in general, if the APA and the AMA, American Medical Association, if they don't have the unconscious defined accurately, if they don't have addiction defined accurately, of which our work does, the addiction as dissociation model, we believe, and dissociation is questionable to a lot of people in the field, or enough people in the field that they're not getting what we're saying, and it may be because they're dissociative. And there have been a couple recent articles published, particularly on brain spotting and EMDR, or at least one was a article in a journal. The other one, I think, was more of a piece, blog type of thing. I didn't actually get that yet. But I will, do like a reading in this channel. And that is for a profession of a healer. A healer is not going to entertain diagnoses farther than they have to, in the sense of, like, the human being that is suffering. Labeling what is what, clients don't necessarily care. They just want the help, they want the relief, they want the person in their lives who can be there for them in a way that others haven't been able to. And that's usually a replication of the developmental trauma. Now, at the core of the developmental trauma is trust, and the attachment trauma definitely, as far as trust and stuff like that, and people experiencing the need to have somebody support them, and or even the inner world of, inner children that need to have a parent that is replacing what they didn't get or rewriting the story in a new way. Now, this is a very, a quick crash course in, what is transference and what is used in therapy to be able to help use and using the therapeutic relationship and dynamic. Now, I have been through those trainings, and I have yet to see how we heal developmental trauma disorder in a cognizant way. There are methods and approaches, and they have been for the last 10, 15 years, they have been coming out and they have been there. And I would argue that, developmental models have been there. But if it's not a diagnosis, then it is not something that you would need to have a license to be able to do. So, my plea for Kolk to not push this is centered around concerned about the control of the models and or the APA and the AMA and who they're talking to as far as governmental, agencies and the, in general, the governance and what it implies that if we start treating normal more than we already are. Now, the other flip side to this is counselors, therapists and psychology, they may not be happy that the fact that I'm calling out that these things are not developmental traumas, and probably, anywhere from like 75 to 90% of your time is doing something that's not billable. Well, the clients need the help, right? So we're willing to compromise our values. But on the other side, if we're going to actually follow the research, maybe we start following the research we do have instead of the research we don't have with some of the more modern, COVID response rollouts. Let's follow the research we do have, and here's, the outline that I would, offer people to, try to convince them to, see what I see in that sense. And, starting off with, 1980, abnormal response, abnormal event, to 94, 96 in there, Judith Herman, her work, highlighting that this is a normal response to a normal event. So, why, for the last going on roughly 30 years, are we treating something that is not a diagnosable disorder? Well, it's because people have this need. There's no doubt that the need is there, but is it diagnosable, or can we have more of a middle ground? And when we think about like mental health compared to like physical health, and this is, the reason why I have created what I've created, is that why don't we have a gym model for our mental health? That's something we all have it. Like, we all have physical health, and if we don't have it, we know it. Like, looking at somebody with alopecia, like, I have a physical health issue, apparently, that is manifesting in my skin or a lack of hair. So I still have physical health, but I also have an illness. I can live with it, and I can deal with it, and maybe I can treat it. Maybe I can't. Maybe there is no getting better. There comes a point in our healing process that we have to accept that this is as good as it's going to get. Or, take the risk of, finding something else out there that could help. Now, I respect the need for clients to have their needs met, and clients don't need to necessarily be too much a part of this conversation. However, the internet is, and I would even argue AI, is giving us a much different run for our money, particularly around like being able to like ask, ask the internet, Wikipedia, for your diagnoses, or at least you can start tracking it down. Research does not have to be done by a scientist in a traditional sense in order for you to be able to find an answer online, which, if we can all find the answer, then there really isn't too much of a specialty in the diagnostic kind of field. People can kind of get into the area, but like, you want to get it confirmed, and that's why people come to us. And sometimes people are just coming to us as mental health professionals just to kind of confirm that they're not crazy. Well, nobody's crazy, and that is like part of the condition in which having labels have set it up. my concern is that like we'll start medicating normal more than we already are. We, in a sense, have compromised our need to help people too much by labeling things that aren't a diagnosis just so we can bill. Now, that does not mean like, it doesn't mean stop helping people or whatever, but like it definitely calls a wisdom to come through. And when we look at the guidance of the medical model, I had concerns for, the COVID response in general, as far as lockdowns and social distancing and masking, and even, the vaccine, which has, kind of shown itself now to be more of a flu shot. The research at the beginning was much higher efficacy than it is now. And the rollout and my work particularly kind of, spoke to, rolling out a vaccine against kind of against natural immunity, but also autoimmune conditions. I had hypothesized before the COVID vaccine came out that like a drug use can produce and trigger stress related responses, particularly illness. Gabor Mate talks about it in his book, and Dr. Robert Scare also talks about it in his book, 2005, The Trauma Spectrum, and then Gabor Mate's When the Body Says No. I believe that was 2003. So that framework and erosion of civil liberties, heightened censorship, this dynamic between qualitative and quantitative. These are showing me a lot of concerns that if we start to diagnose things that are normal won't exist. And that isn't going to be used for people's benefit in the long run. And we will look back on this and we will regret it. So appreciate, van der Kolk's work, and I'm sure he, could rebut in a way that would probably, help me open my mind to certain things. But I also think I've read enough of his stuff and heard him talk enough to know that like he probably has this concern too. And I think in The Body Keeps the Score, he talks about like, trauma therapists being in a sense, voyeurs, witnessing people's trauma histories and, kind of talking about how, this person has survived such amazing or, debilitating, ways and things, and their amazing stories. And, part of what I would argue is that we're addicted to the stories. Those are some of the earliest drugs that we have. And also that we can become addicted to the healing process. We can become addicted to the traumatizing process of trying to reprocess our traumas and stuff like that. And, that's not me saying it. That's van der Kolk. So, addiction really does offer a much broader understanding of mental health. And my dissertation and my work, speaks to how that's going to roll out, particularly in the age of psychedelics. And, I think it's great that, people are healing. I have been doing this long enough where I have seen people heal enough to, repair a lot of their life and grow from it. I've also seen most need ongoing type of like a gym membership for their mental health, which doesn't have to be, pathology. And, I really have to question if creating pathology isn't a pathology in itself. So just some thoughts there. Hope you enjoyed, and see you around.